Welcome to the deep dive.
Today, we're really getting into something quite confronting. Think about those forces involved in, say, a bad car crash or interpersonal violence, even sports impacts.
Yeah, serious stuff.
We're talking about maxillofacial trauma, those really complex, sometimes devastating injuries to the face, head, and neck.
Exactly. And our mission here with the source material you shared is to properly dig into it. We're not just going to skim it.
No way.
We want to get right down into the weeds, understand all the nuances, and really aim for that level of knowledge where, you feel like you're right there with the specialists managing these cases.
Mastery. That's the goal.
Absolutely. We're aiming for mastery of this information.
So we'll cover the whole picture, starting with the immediate emergency stuff, then how these injuries are classified, walk through the whole examination process, and then really dive into the specifics like different bone fractures, soft tissue damage, and how it's all managed. And it's so important to remember, like, the source stresses, these aren't just superficial. They can be immediately life-threatening.
Right. They demand really urgent systematic care.
Totally.
Okay, let's unpack this then. This is starting right at the sharp end. Those first critical minutes when a patient comes in, what's the absolute #1 priority?
Always, always. It's the life threats first. Following the ATLS guidelines, ABC, airway, breathing, circulation.
And with facial trauma, the airway. That's often the biggest immediate danger, isn't it?
Oh, absolutely. It can be the most terrifying part. The injuries themselves can physically block it.
It's not just about blood then.
No, not at all. The source points out a really dangerous scenario, severe mid-face injuries where the maxilla, the upper jaw, is kind of detached from the skull base and pushed back.
Oof.
Yeah, and especially if the mandible, the lower jaw, is broken on both sides too, it can just make the tongue fall backwards.
And just block the throat completely.
Yeah, like a plug. Exactly. And then you get this massive, rapid swelling edema of the soft palate, the tongue itself. That whole space just shrinks incredibly fast.
So while you're trying to sort out a definitive airway, are there things you can do right there immediately?
Definitely. If the patient's unresponsive, you can literally grab the front of the maxilla and pull it forward. Try and open things up.
Physically pull it.
Yeah. And you can grab the tongue, too, sometimes. You actually need a big suture or even a towel clip to get a grip in a trauma situation and pull that forward.
Wow.
And absolutely crucial, constant high-volume suction. You've got to clear out blood, bits of teeth, any debris.
Okay, so that buys you some time. But if it's not enough, what's the next step? The definitive airway.
Well, that means securing it properly so it can't be lost again. Endotracheal intubation, getting a tube into the windpipe through the mouth or nose, that's the standard.
But if the face is too damaged?
Right. If the swelling or the distortion makes that impossible, you've got to be ready for plan B or C. That might be a needle cricothyroidotomy or going straight to an emergency surgical airway, making an opening directly into the trachea through the neck. Knowing how and when to do those is vital.
Okay, airway first. But the face bleeds a lot. Bleeding must be a massive concern, too.
It can be catastrophic, yeah. Deep cuts, penetrating neck wounds, high-energy impacts, they can easily involve major blood vessels.
Where's the bleeding typically coming from?
In the midface, you worry about the maxillary artery or this network of veins called the pterygoid venous plexus. Big bleeders. Down in the neck, it could be branches of the external carotid artery or veins draining into the internal jugular.
How on earth do you control that kind of bleeding?
Well, direct pressure is always step one if you can get to the source. For really bad nasal bleeding, which is common with midface fractures, you need specialized packs, anterior and posterior nasal packs.
By packing the nose.
Yeah, exactly. The source mentions inflatable balloon packs, or even using things like Foley catheters modified to basically tamponade the bleeding from inside the nasal cavity. And sometimes just getting that stable airway, the tube or the surgical airway, is needed partly just to manage the sheer volume of blood or the swelling that's happening.
Okay, so beyond the ABCs, the assessment has to be wider, right? You can't just focus on the face.
Absolutely crucial. Any significant facial trauma, you have to suspect a potential severe head injury. The source really emphasizes this.
Especially if they're intoxicated or something.
Exactly. Violence, accidents. Patients are often intoxicated, or other injuries can mask the symptoms of a brain injury. So you need a really low threshold for getting a CT scan of the brain.
It makes sense.
And when you do that brain CT, it's usually sensible to include the facial bones in the same scan. Kill two birds with one stone.
And the eyes. The source really flags the risk of losing sight.
This is where it gets really critical and time sensitive. Mid-face fractures often involve the orbits, the eye sockets. Damage there can lead to blindness incredibly quickly if you don't spot it.
Like what kind of damage?
The source specifically calls out retrobulbar hemorrhage. That's bleeding behind the eyeball.
Okay.
It causes this intense pressure on the optic nerve. And if that pressure isn't relieved, like now, it cuts off the blood supply and vision loss becomes permanent. It's a massive emergency. Sight-threatening.
Got it. Okay, so you've dealt with the immediate life threats,
Right.
started the broader look.
Yeah.
Now, to actually understand and talk about the injury, you need ways to describe it, right? How are these injuries classified?
Yeah. Classification is key. It gives everyone a common language, helps understand the pattern, guides the management. For bony injuries, we first talk about the type of fracture.
Like how it's broken.
Exactly.
Right.
Is it simple, just a single clean break, compound where the bone breaks through the skin or into the mouth, so it's open to contamination?
Right, risk of infection there.
Definitely. Or is it comminuted, shattered into multiple fragments? Complicated meaning it involves important nearby structures like nerves or blood vessels.
Okay.
Then there's green stick fractures, incomplete breaks. You see them more in kids. And pathological fractures, breaking through bone that's already weak from some disease process. And you also note if it's undisplaced, minimally displaced, or really significantly shifted.
So that's what the break looks like. And then where is it? That vertical thirds thing.
Spot on. Imagine dividing the face horizontally. The upper face is basically from the inner corners of the eyes upwards, forehead, frontal sinuses.
Okay.
The mid-face runs from the upper teeth up to those inner eye corners. That includes the maxilla, zygoma, orbits, nasal bones.
And the lower face?
That's the mandible, the lower jaw, and the lower teeth. And within that mid-face section, you can divide it again. Central, which is the nose and the sort of ethmoid complex around the orbits.
Nasoorbital ethmoidal.
Yeah, that's the one. And lateral, which is mainly the cheekbone area, the zygomatico-maxillary complex.
So orbital fractures, eye socket fractures, they fall under midface.
They're usually considered part of the midface complex. Yeah, those sometimes they happen on their own. And they get classified by which wall is broken the floor, the medial wall next to the nose, the lateral wall by the temple or the roof.
What about the really big complex ones that involve the skull too?
Right. If you have skull fractures, especially involving the frontal sinuses combined with facial fractures, that's a craniofacial fracture. These are really serious, need joint neurosurgical and maxillofacial team input because of the brain injury risk.
Okay.
Frontal sinus fractures themselves have their own classification, front wall, back wall, or involving the drainage pathway, the nasofrontal duct.
And the most severe overall.
That would be panfacial fractures. Fractures affecting multiple levels, mandible, midface, and upper face all at once.
That sounds like massive force involved.
Huge force. A panfacial fracture is a major red flag. It tells you there was high energy trauma, and you should strongly suspect other serious injuries elsewhere in the body that need finding.
And just quickly, soft tissue injuries, cuts, bruises.
They get classified too.
Oh.
Usually by the cause, crushing from blunt trauma or incise from something sharp, whether there's actual tissue missing. And if they're through and through connecting the skin outside to the inside of the mouth or nose.
And they can hint at bone damage underneath.
Often, yeah. The location and type of soft tissue injury can be a clue to what's going on with the bones below.
Okay, so we have all these classifications. How do clinicians actually gather all this information systematically from a patient?
It starts with a really meticulous clinical assessment. And the history is just vital. The mechanism of injury, how it happened, tells you so much.
Like blunt versus sharp.
Exactly. Clean versus contaminated, how much energy was involved. It helps you predict what hidden injuries might be lurking.
Like knowing a certain impact means you have to check the next spine.
Precisely. You also need their medical history. Are they fit for an anesthetic? Social history can be relevant. What happened after the injury? Get info from witnesses, first responders if possible. And don't forget tetanus status. Super important for contaminated facial wounds. Need that booster quickly if they're not up to date.
Okay, then the physical exam. Back to ABCs first.
Always. Primary survey. Airway, breathing, circulation. Check their neurological status GCS score. And crucially, protect that cervical spine. Assume it's injured until proven otherwise.
Then look into wounds.
Initial wound assessment, yeah. Dress them. Note the size, location, depth. And the source is really clear. If you see a penetrating foreign body sticking out.
Don't just yank it.
Exactly. Especially if it looks large or deep. Leave it alone. Get imaging first and plan removal in the operating theater where you can control potential bleeding.
Got it. Then the secondary survey, the head to toe.
Yes, and it needs to be systematic. Top down is a good approach. Scalp, back of the neck, ears, Then look at the face from the front.
Check nerves.
A brief cranial nerve exam, yeah, especially focusing on nerves likely affected by the injured area. And really examine that cervical spine.
Why the emphasis there again?
Because spinal injuries associated with facial trauma, especially high-impact ones, are missed surprisingly often in the initial chaos. You have to specifically look for them.
Okay, let's zoom back in on the eyes. The source really highlights this part of the exam.
The eye exam is maybe one of the most challenging bits in mid-face trauma, but it's absolutely critical. Check the tissues around the eye, the position of the eyeball itself. Is it sunk in, pushed forward?
Visual acuity.
Test vision, definitely. Ask about double vision diplopia. Measure the distance between the inner corners of the eyelids looking for telecanthus. Check how the eyes move in all directions.
But what if it's massively swollen? How do you even see the eye?
That's a really common problem. The source gives some practical tips. Use a bit of dry gauze or a cotton bud, even a microbiology swab stick to gently try and lift the eyelids.
Gently does it.
Very gently. Sometimes just applying gentle pressure for a moment can reduce the swelling enough to get a quick look. But you have to try. You need to rule out an injury to the globe itself or that critical retrobulbar hemorrhage we talked about. Delay here could mean blindness. The urgency is immense.
Right. After the eyes, systematically feeling the bones.
Palpation, yeah. Feel along the bony edges.
Yeah.
Supraorbital ridge above the eye, the lateral rim, the infraorbital rim below the cheekbone itself, the zygoma, the nasal bones. Feel the jaw joint, the TMJ, and trace the whole lower jawline, the mandible.
What are you feeling for?
Steps. Little step deformities where the bone is broken, point tenderness, asymmetry compared to the other side. Those are the classic signs of a fracture.
And then inside the mouth. Must be tricky sometimes.
It definitely needs a good look, good light source, suction ready for blood or secretions. Look for cuts on the gums, cheeks, tongue, bruising, hematoma, especially in the floor of the mouth, and then the teeth.
The teeth assessment sounds really detailed in the source.
It is, and for very good reason. You need to note exactly which teeth are present, which are missing. And for the ones there, what kind of injury? Are they knocked, clean out, avulsed? Are they loose or shifted, luxated? Or are they fractured?
And why is accounting for missing teeth so critical?
Because if a tooth or a fragment is missing, you absolutely must know where it is. The big danger is aspiration, inhaling it into the lungs.
Oh, right.
So if you can't find it in the mouth or the wound, you need a chest x-ray. No question. Check the airway.
And the bite, how the teeth meet.
That's a key sign. Altered occlusion, the bite feeling off, it's often one of the first things the patient notices, especially with displaced jaw fractures, upper or lower.
What else points specifically to a mandible fracture?
Look for a tear in the gum tissue directly over the suspected fracture line. A hematoma, that collection of blood in the floor of the mouth, is a strong sign. And check sensation in the lower lip and chin numbness or tingling suggests damage to the inferior alveolar or mental nerve.
Okay, history and exam done. Then investigations. Imaging seems unavoidable.
Pretty much. Imaging is guided by what you suspect. You'll do routine bloods too, of course. For the mandible, if you suspect a fracture, the standard x-rays are an OPT, that panoramic view.
Right, the one the dentist takes.
Exactly. And a PA view, posterior-anterior. The source stresses getting two views at right angles to each other so you don't miss anything. If the patient really can't cooperate for an OPT, a basic lateral view might give some information.
And for the midface?
Standard x-rays are occipitomental views, OM views, usually taken at 10 and 30 degrees.
That CT is the best.
Yeah, CT is really the gold standard now for looking at facial bones properly, especially for orbital fractures or anything high impact. And like we said, if there's any whiff of a head injury, the CT must include the brain.
And 3D reconstructions.
They're incredibly helpful for complex fractures. They give you this amazing 3D picture of the bony structure and exactly how it's broken. Really aids planning.
Okay, so assessment, classification, imaging, all done. Now let's get into the nitty-gritty of management, starting with soft tissues, the cuts and scrapes.
Right, lacerations. The source makes a good point. Examining them isn't just about the cut itself. You're actively looking for damage underneath nerves, ducts, like the salivary parotid duct, or even bone involvement.
When do they get repaired?
Usually within 24 hours. Smaller, cleaner ones might be done under local anesthetic. Bigger, messier ones, or injuries in children, often need a general anesthetic.
Cleaning them properly sounds important, especially if they're dirty.
Crucial. If there's grit or dirt ground in, gentle scrubbing, maybe with a soft brush, is vital. Otherwise, you risk leaving pigment behind a permanent dirt tattoo as it heals.
Do you cut much tissue away?
Not usually on the face. It has such a good blood supply, you only debride, trim away tissue that's obviously dead, necrotic. You want to save as much as possible.
And stitching them up.
Inside the mouth, small cuts often heal fine on their own, especially in kids. If you do suture intraorally, or for the deep layers of a skin wound, you use dissolving resorbable sutures.
And on the skin surface.
For the best cosmetic result, fine, non-dissolving monofilament sutures like a 5-0 or 6-0 nylon are usually preferred. You might use dissolving ones sometimes in kids or perhaps adults who won't come back for removal.
What about tissue glue? So that used?
Yeah, cyanoacrylate glue can be good for small, clean, straight cuts, but there's a big warning in the source. Never use it near the eyes, on the periocular skin.
Right up.
Because even a tiny drop getting into the eye can cause really severe damage to the cornea, so avoid it there.
Makes sense. And appearance is obviously a huge deal in the face.
Absolutely. Cuts that cross important cosmetic lines like the edge of the eyelid or the red margin of the lip, the vermilion border need incredibly precise alignment during repair to avoid a noticeable step or notch later on.
What if tissue is actually missing?
For small amounts, you might be able to undermine the surrounding skin a bit, stretch it to close the gap. But the source says complex repairs like local flaps or skin grafts are usually not done in the initial repair. Very large defects might eventually need major reconstruction, like a free flap later on.
And nerve or duct injuries. Sounds tricky.
They are. You should always check facial nerve function. If a branch is cut, the source says repair is generally indicated if the injury is lateral to a line drawn down from the outer corner of the eye.
How's the repair done?
Ideally, primarily, soon after the injury. It needs high magnification, usually under general anesthetic. Sometimes a nerve stimulator helps find the cut ends.
And the parotid duct, the saliva duct.
It runs roughly from the earlobe towards the middle of the upper lip. If it's cut, you might see saliva leaking into the wound. You can confirm by injecting a blue dye into the duct opening inside the cheek.
And repair that too.
Yes, again, under high magnification. You usually stitch it over a tiny fine tube, a cannula, to keep the duct open while it heals. And the buccal branch of the facial nerve runs very close by, so you have to be careful and check its function.
What about bites? Animal or human? They sound nasty.
They need really, really thorough cleaning because of the bacteria. Primary closure is usually done for facial bites, but antibiotics are essential. Local guidelines will dictate which ones.
Human bites raise other concerns.
Yes, the source specifically mentions considering HIV and hepatitis testing if the circumstances suggest a high risk. Significant tissue loss from bites might need reconstruction in stages later on.
Okay, let's move on to the bones. Mandible fractures, you said they're common.
Very common, and often they break in more than one place. The source highlights typical patterns, like a break near the chin, parasymphysis, combined with one at the angle of the jaw. Or a chin fracture with a break in the condyle, the joint part, often on the opposite side.
Where do they usually break?
The most common spots are the neck of the condyle, then the angle, then the region around the mental foramen where that nerve comes out.
Ah, yes, the nerve. Inferior alveolar or mental nerve.
Gotta check its function, document it. Numbness or altered sensation paresthesia in the lower lip or chin is a really important sign of potential nerve involvement.
How are mandible fractures fixed?
Most displaced ones need surgery. Open reduction and internal fixation, ORF. That means surgically exposing the fracture, putting the bones back in the right place, reduction, and fixing them with small titanium plates and screws. Done under general anesthesia with antibiotics.
What if it's not just placed?
Undisplaced fractures can often be managed conservatively. Antibiotics, pain relief, a strict soft diet for about 4 weeks, but they need careful watching to make sure they don't shift or fail to heal.
You mentioned plates, miniplates versus reconstruction plates. What's the difference?
It's about how they handle the load, the biting forces. Miniplates are smaller, usually fixed with screws that just go through one side of the bone cortex. Their load sharing the plate helps stabilize, but the bone itself still takes some of the force once it starts healing.
Okay.
For really smashed up, come-on-ended fractures or areas under high stress, you might use heavier reconstruction plates. These often use screws that go through both sides of the bone cortex, bicortical. They're load-bearing. The plate takes pretty much all the force, protecting the fractured bone fragments.
How many plates do you need?
Depends on the location. For angle or body fractures, often a single mini plate along the top edge is enough to counteract the tension forces. For fractures near the chin, you usually need 2 plates to stop it twisting.
And that transbuccal approach for angle fractures.
Yeah, the source mentions that. It's using a small incision through the cheek to get better access and allows the surgeon to place the screws at the ideal angle for stability at the jaw angle. It's biomechanically stronger.
Condyle fractures, the joint ones, sound complex.
Most are actually treated non-surgically, believe it or not. Closed reduction, maybe using elastics between the teeth, IMF, to guide the bite, plus a soft diet.
But sometimes surgery is needed.
Yes, particularly for commular neck fractures that are significantly displaced and cause the jaw to shorten vertically. These are increasingly treated with ORAFF now. The surgical approaches can be tricky, often via an incision near the ear or behind the jaw, retromandibular. Endoscopic techniques are also becoming more common.
Timing matters for surgery.
Ideally, yes. Optimal time for ORFS is often within 24 to 48 hours. If surgery has to be delayed longer, sometimes putting a temporary wire around the teeth, a bridle wire, can help pull displaced fractures closer together, which eases pain and helps the patient drink.
Okay, moving up the face. Zygoma fractures the cheekbone.
Often from blunt force, like a punch, yeah. The source uses a helpful analogy. Think of the zygoma like a 4-legged stool.
Okay.
The legs are its connections. The zygomatic arch sticking out, the bit connecting to the frontal bone near the eye, the connection to the infraorbital rim below the eye, and the bit connecting to the maxilla, the buttress. Fractures usually involve breaks at one or more of these legs, and often the orbital wall gets broken too.
Swelling makes them hard to see initially.
Definitely. Patients often get reviewed about a week later when the swelling has gone down a bit. Signs to look for are the obvious cheek swelling and bruising, feeling a step where the bone edge is broken, and bruising in the white of the eye, subconjunctival hemorrhage. Specifically, the source notes, if it doesn't have a clear back edge, it suggests the orbit is involved.
And you always need imaging.
Always need a CT scan of the orbits to properly see the cheekbone and check for those associated orbital floor or wall fractures.
How are they managed?
If it's undisplaced, often just conservatively. Soft diet. Avoid putting any pressure on the cheek for maybe 3 weeks. Surgery is needed if it causes noticeable asymmetry, like a flattened or sunken cheek.
Or if it affects the eye.
Yes, if there's persistent double vision, or the shape of the orbit is changed, or sometimes if the broken cheekbone piece actually blocks the jaw from opening properly, impinging on the coronoid process of the mandible.
What kind of surgery is done?
Approaches can be through small skin cuts, maybe in eyelid creases or from inside the mouth. Sometimes close techniques are used, manipulating the bone back without directly seeing the fracture, like the Gillies lift, using an instrument passed under the skin from an incision in the temple, or Keen's technique, going from inside the mouth.
Or plating it.
Yes. ORIF uses small, low-profile 1.5 millimeter mid-face plates and screws placed at the fracture points. How many points you fix 1, 2, 3, or even all 4 legs depends on how unstable the fracture is after you put it back together and how comminuted it is.
Okay, up again. Maxillary bone fractures, the upper jaw.
These are often described using that classic Lefort classification. Remember René Lefort? He described 3 main patterns based on cadaver studies.
Lefort-Thurs 2 and 3.
Exactly. Lefort-Thurs is basically a horizontal fracture separating the lower maxilla, the part with the teeth, from the rest of the midface. It runs above the tooth roots across the bottom of the nose.
Okay.
Lefort-3 is more like a pyramid shape. It involves the maxilla, the nasal bones, goes up across the bridge of the nose, and involves the lower rims of the orbits.
And
the 4/3 is the highest level, sometimes called craniofacial disjunction. The entire midface skeleton basically breaks away from the skull base. The fracture line runs through the orbits, across the nasal bridge, and through the zygomatic arches.
But you said reality isn't always that neat.
Correct. It's a useful framework, but real-world fractures are often messy, asymmetrical, shattered in places, maybe combining features of different Lefort levels. They don't always follow the lines perfectly.
So how are they managed?
Again, if undisplaced, maybe conservatively. ORIF is needed if the maxilla is mobile or unstable. If the bite is significantly off, like an anterior open bite where the front teeth don't meet, or if there's a loss of facial projection or width.
And fixation uses those buttresses.
Exactly. You use those 1.5 mm minute plates, and you place them strategically along the facial buttresses. These are the naturally thicker, stronger pillars of bone running vertically and horizontally across the face. They provide the best anchor points for the screws to hold everything stable. The source really emphasizes looking at diagrams to understand where these buttresses are.
Okay, back to orbital fractures again, since they seem to pop up everywhere.
They do, can be isolated or part of zygomaxilla fractures. The floor is the most common site to break.
Blowout fractures.
That's the classic type. Pressure inside the orbit, like from a fist or ball, pushes the thin floor or medial wall outwards into the sinus below. Orbital fat, sometimes even muscle, can herniate through the hole. There are also blow-in fractures where bone fragments push into the orbit.
What are the symptoms of a floor fracture?
Difficulty looking upwards is classic, along with double vision. This happens if orbital tissue, or crucially the inferior rectus or inferior oblique muscles, get trapped in the fracture line.
Is that oculocardiac reflex?
Yes. The source highlights this, especially in kids. If a muscle gets trapped, it can trigger this reflex slow heart rate, bradycardia, nausea, even fainting. It's a surgical emergency because that trapped muscle can die from lack of blood supply quite quickly. Sometimes these are called trapdoor fractures or white eye blowouts because there might not be much external bruising.
And if they're not fixed, what happens long term?
Once the initial swelling goes down, maybe after 2 to 4 weeks, you might start to see changes in the eye position. Hypoglobus, where the eye sinks downwards, or in ophthalmals, where it sinks backwards into the socket. Both happen because the bony orbital volume has increased.
So when do orbital fractures need surgery?
The main reasons are significant ophthalmos causing cosmetic issues or persistent double vision that's confirmed to be due to muscle entrapment. An assessment by an orthoptist can help figure out if it's true trapping versus just muscle bruising or nerve issues.
How are they repaired?
If the orbital rim is broken, that gets fixed with plates and screws, ORIF. The walls themselves, the floor or medial wall, are usually reconstructed using thin implants, often made of titanium mesh. Less commonly now, bone grafts might be used.
And let's reiterate that emergency retrobulbar hemorrhage.
Absolutely critical. It leads to blindness fast. The signs are a really tense, bulging eye proptosis, increasing pain, vision dropping rapidly, maybe the pupil stops reacting, or they perceive red colors differently.
What do?
If you suspect it, you act immediately. You don't wait for a CT scan to confirm.
Yeah.
Bedside emergency, lateral canthotomy and cantholysis.
Cutting the corner of the eyelid.
Yes. Under local anesthetic, you make a cut at the outer corner of the eyelids and then cut the lateral camphal tendon. It releases the pressure, decompresses the orbit, it's sight-saving. Plus, medical management alongside, like mannitol, cetazolamide, steroids.
Okay, nearly at the top. Frontal sinus fractures.
These mean significant force hit the forehead. High risk of associated brain injury underneath.
What are the specific risks?
A tear in the dura, the lining of the brain, causing cerebrospinal fluid CSF to leak out through the nose. CSF rhinorrhea. You need a special test, a substitute-transferrin assay, to confirm the fluid is actually CSF.
How are they classified?
Based on whether the anterior front wall, the posterior back wall, or both are broken. And crucially, whether the sinus floor involving the drainage pathway, the nasofrontal duct, is injured.
And the goal is a safe sinus.
Exactly. That means making sure it can function and drain normally, protecting the brain from infection coming up from the nose, and preventing long-term complications like meningitis, abscesses like Pott's puffy tumor, or mucus-filled cysts called mucosiles.
So management depends on what's broken.
Pretty much. Minimally displaced fractures, less than about 2 millimeters, involving just the front or back wall without duct injury, might be managed conservatively with observation.
When is surgery needed?
If the front wall is significantly disrupted, causing a cosmetic deformity, if the nasofrontal duct is definitely involved or blocked that needs fixing to prevent mucocele, or if the posterior wall is displaced, especially if there's neurological injury or a CSF leak.
What kind of surgery?
For just the anterior table, you might access it via a coronal flap incision in the hairline, reduce the fragments, and plate them. If the posterior table is involved, it's often a joint case with neurosurgery. They might perform cranialization.
What's that?
It involves removing the damaged posterior wall, completely clearing out the sinus lining, plugging the nasofrontal duct, and often using a flap of the scalp lining, pericranial flap, to separate the brain cavity from the nasal cavity. Follow-up CT scans months later are vital to check for complications.
Okay, nearly there. Isolated nasal fractures. Very common.
It's super common. Often the true extent of the crookedness isn't clear until the swelling goes down, so patients are often seen back in clinic after about a week.
When do they need fixing?
Usually for cosmetic reasons, or if the break causes significant nasal obstruction, difficulty breathing. Often, a closed reduction can be done.
Just pushing it back into place.
Basically, yeah, using instruments, sometimes just fingers, often under local anesthetic, though general is used too. Then a splint is put on the outside for a week or so.
And nasoethmoidal fractures, they sound more serious.
They are. They involve the thin bones right at the top of the nose and the ethmoid sinuses behind it, result from significant force, often shattering the bone.
What are the telltale signs?
Classic signs are bruising around both eyes, bilateral periorbital ecchymosis, a flattened or sunken nasal bridge, sometimes the nasal tip looks upturned, a piggy nose appearance, and critically, telecanthus.
Telecanthus.
That's an increased distance between the inner corners of the eyelids. The pupils are the normal distance apart, but the inner corners have spread wide. It happens because the medial canthal ligament, which anchors the inner eyelid, gets detached or displaced with the fractured bone.
What else to check?
Always check the nasal septum inside for a hematoma, which needs draining, and rule out a CSF leak.
And spotting that telecanthus early is vital.
Hugely important. If it's missed or treatment is delayed too long, it becomes incredibly difficult to accurately reposition that canthal ligament attachment later on, leading to a permanent widening between the eyes. Repair is often delayed, maybe 7–10 days for swelling to settle, but identifying the problem early is key. The surgical challenge is getting that ligament back in exactly the right place amidst all the broken bits.
Right. The most severe, again, panfacial fractures.
Just to recap, fractures at multiple levels, mandible, maxilla, zygoma, orbit, often frontal too, signifies really severe trauma, high chance of other serious injuries throughout the body.
Assessment.
3D CT is invaluable for understanding the full extent and planning the repair.
Management.
It's ORIF, fixing everything with plates and screws. But you usually have to wait until the patient is stable from their other injuries and the worst of the facial swelling has subsided, typically about a week.
How do you even approach fixing something so extensively broken?
The key concept is sequencing the repair. You have to decide what to fix first, second, third. Because so much is broken, you use the few remaining stable or normal anatomical landmarks as your starting points and build out from there.
Is there a standard sequence?
A common approach is top-down and outside-in. So you might start by fixing the stable upper framework, the frontal bone, the zygomatic arches, then work down to the orbital rims, fix the nasoethmoidal complex, then stabilize the mandible. The Lefort eye-level fracture and the orbital floor repairs often come last. But it has to be tailored to the specific fracture pattern.
And managing the airway during such a long, complex operation.
A tracheostomy is frequently needed. Nasal intubation might be impossible due to the fractures, and having an oral tube in the way makes it impossible to check the patient's bite properly during the surgery, which is essential.
Alternatives.
Submental intubation is an option. That's where the breathing tube is passed through a small incision under the chin, getting it out of the mouth but avoiding a tracheostomy. It allows the surgeon to close the mouth and check the occlusion.
Okay, last area, dental injuries. Often go hand in hand with facial trauma.
Absolutely. Good to remember the basics: primary baby teeth versus permanent teeth eruption times.
Types of injury.
Can range from simple chips of the enamel to fractures involving the underlying dentine, maybe even exposing the pulp, the nerve inside. Pulp exposure is usually painful and needs at least a temporary dressing quickly.
What if a tooth gets knocked right out?
Pulsed. For primary teeth, baby teeth, you don't try to put them back in.
Hmm.
For permanent adult teeth, the best thing is to reimplant it back into the socket immediately, right there, if possible.
If you can.
Store it properly. Best options are milk, the patient's own saliva, if they can manage it, or saline solution. Get to a dentist ASAP. A reimplanted adult tooth needs splinting.
Splinting?
Yeah, attaching it to the neighboring teeth, often with a wire and composite resin or a custom splint, usually for about 2 weeks, plus antibiotics, antiseptic mouthwash, and check tetanus status.
What about teeth that are just loosened or moved? Luxated.
Adult teeth are gently repositioned into the correct place and splinted for longer, maybe 4 weeks. If a whole segment of jawbone breaks off with the teeth still in it, a dental-alveolar fracture, that segment is repositioned and splinted, also usually for 4 weeks. Luxated primary teeth are often managed conservatively or extracted if they're interfering with the bite. And circling back one last time, account for every missing tooth or fragment. check the airway, get that chest x-ray if needed. And all these dental injuries need proper follow-up with a dentist for things like splint removal, checking tooth vitality, and further treatment.
Wow. Okay. We have really covered a huge amount of ground there, working through the source material, from that initial rapid emergency care
Yeah, the ABCs.
through understanding the language of classification, the systematic way clinicians examine these
There's
injuries,
that top-down approach.
and then diving deep into the principles for managing such a wide range, from soft tissue cuts right up to shattered panfacial fractures and those crucial dental injuries.
And by going through it like this, you really build that robust framework, don't you? You get the specific details, the terminology. You appreciate the sequence, the critical steps involved. It really is that foundational knowledge that underpins true expertise in this field.
You really feel like you've done that deep dive.
Definitely. We've aimed for that level of mastery with this material.
Thinking about all those layers, though, from the immediate life-saving actions to the incredibly meticulous, almost artistic reconstruction, trying to restore not just function but form.
It just highlights that incredibly complex link, doesn't it, between our facial structure, how it works, and fundamentally our sense of identity.
Absolutely. It makes you consider, how trauma, this part of us, the part we present to the world, the part so involved in communication and eating and breathing, how it challenges not just the physical body, but maybe a person's whole sense of self, their interaction with everything.
That's a really powerful thought to leave with, something definitely worth pondering next time you encounter a story about facial injury, or indeed about resilience in the face of it.